Thank you very much. Good afternoon. My name is Maggie, and I'm actually a final year medical student at University College London. I am very interested in dermatology, and so during my attachment at the Royal Free Hospital, I got involved with this pilot teledermatology service that I'm presenting today. First, do we need teledermatology? The red dots on this London tube map show us all the dermatology units in central London, and we are based at the Royal Free Hospital, which is here. And however, our hospital trust also covers Barnet and Chase Farm hospitals, which are north of here off the tube map, somewhere up here. And so in total, our three hospitals cover a huge catchment area of nearly 1 million people, and it's a predominantly Caucasian population compared to the other hospital trusts in London. The Royal Free is one of the biggest tertiary referral centres in London for suspected skin cancer lesions. We receive over 6,000 referrals per year under the 2-week wait pathway, which is a nationally guided GP referral route for the assessment and management of suspected cancers, significantly more than our neighbouring London trusts. Under this pathway, all patients should be seen by a specialist within 2 weeks of referral. Like many hospitals, the number of 2-week wait referrals we receive are rising annually. There has been an over 50% increase in the past 5 years. The reason for this are not only due to an aging population, but also because patients are more aware of skin cancers. In addition, the threshold for specialist referral has also lowered, both due to patient expectation and anxiety, as well as many GPs using the 2-week wait pathway to bypass the routine 18-week clinic waiting time. Like many hospitals in the country, it is difficult to meet the increasing demand of the current resources. Therefore, we need to look for safer and more effective clinical pathways. We know from published studies that on average, only around 10% of 2-week wait referrals actually end up fulfilling the 2-week wait criteria in being melanomas or squamous cell carcinomas. An audit at our own trust in March 2016 showed a similar but even lower result at 7%. As such, there are potentially a large number of patients who do not need to be seen in a 2-week wait clinic. In short, do we need teledermatology? The answer is a resounding yes. Our main aim for piloting teledermatology service was therefore to reduce the number of face-to-face referrals for benign lesions, and through this improve convenience for patients as well as maximize resources for those with actual skin malignancies. It is also a valuable educational tool for GPs. To our knowledge, we are the first London teaching hospital piloting this. To assess our telederm service, we use the standards set by the British Association of Dermatologists as a benchmark, as listed here. In particular, we wanted to know what proportion of referrals were brought back for a face-to-face appointment, and therefore the effectiveness of the pathway in reducing unnecessary referrals. We retrospectively analyzed data from e-referrals, clinic letters, and biopsy results over a period of 18 months. We recruited a local GP practice with 3 participating doctors. Cameras and the DermLite 2 Pro dermoscopic attachments were given to GPs, and the training was provided by our medical illustrations department. A separate secure NHS email account was set up and monitored by 2 consultant dermatologists on a regular basis. This is a flowchart of our referral pathway, and the referral criteria are listed here. Following review by a consultant dermatologist, there were 3 potential outcomes for the patients. They will either be referred for a face-to-face clinic appointment with our consultant, or discharged back to GP with advice, or they could be booked for surgery directly. This is a copy of the accompanying teledermatology referral forma for the GPs. Just to point out that the gold standard of care is for a full skin check to be undertaken, and this is a tick box for the GPs to indicate whether this has been carried out. For participating consultant dermatologists, there is also a response proforma to standardize responses. We received a total of 80 referrals. 3 were rejected as they didn't meet the criteria. There was almost a 50-50 male to female ratio. We met all of the BAD standards except for photograph quality, where only 65% of photographs were suitable for consultants to provide feedback. This should be 100% as per BAD standards. Of the 77 patients, about a third were offered a face-to-face appointment due to uncertainty or concern about the lesion. This proportion is in line with a previous study in Bristol in 2012. Of these offered a face-to-face appointment, only around half attended. Unfortunately, we could not obtain feedback as to why, although possible explanations could have been that the lesion had resolved, such as in the case of an actinic keratosis, or subsequently not deemed concerning by the referring GP. Of the 52 patients who were discharged back to primary care with a definite benign diagnosis, the majority has seborrheic keratoses, and the other diagnoses are shown here. Of the 13 patients who attended a face-to-face appointment, 4 were asked to come back because of inadequate photograph quality or an inability to make a confident diagnosis. In the end, it turns out to either have seborrheic keratoses or actinic keratoses. 9 patients attended a face-to-face appointment due to a suspicion of possible malignancy and are listed here. This column shows us the initial GP impression of the lesion, and this is the specialist impression based on the e-referral. Roughly 50% of these patients went on to have a biopsy, and these are the final diagnoses. As you can see here, the GP and specialist diagnoses are very similar, and GPs are referring appropriately for this pathway, so no squamous cell carcinomas or melanomas were referred under this service. So, in summary, of the 80 referrals, 77 were included. Of these, we offered a face-to-face appointment to 32%. The rest were given management advice and discharged back to primary care. 50% of the face-to-face patients had a biopsy. The biopsy actually concurred with the pre-biopsy diagnosis, all except for in 2 cases. The majority of the final diagnoses are benign, such as AKs and seborrheic keratoses. For 1 patient, an incidental BCC was picked up during a full skin check at a face-to-face appointment. Interestingly, the accuracy between the GP impression and dermatologist impression were very similar at 77% and 78% respectively. So, in conclusion, this pilot teledermatology service reduced the number of face-to-face referrals for benign skin lesions by 2/3. The main limitation to our study were poor image quality and a very small sample size due to the very few clinicians involved. We also had a significant proportion of patients who did not attend their face-to-face appointment as previously mentioned. To address these limitations, we are in the process of carrying out a further pilot study involving more GP practices. In order to improve the image quality, we have enlisted the Medical Illustrations Department, who have sent out photographers to 2 to 3 hub sites where patients attended with their GP referral performer and have had their images taken and uploaded, which are then reviewed by dermatologists. So far, the results from 164 patients show that the photograph quality has improved significantly, with only 6% of images unsuitable to provide feedback compared to 35% previously. We appreciate that this is an extra cost and an extra step for patients, but this will be offset against the huge savings made from reduced face-to-face appointments, and so far, there has been good patient satisfaction. This slide sets out our vision for our telederm service. GPs will be able to refer patients to medical illustrations in the community, who then will upload the images and referral performer to our online secure platform, Cerner, which can then be accessed by consultant dermatologists. We also plan to carry out more formal assessment as to whether we have achieved the aims of reducing inappropriate 2-week wait referrals, shortening clinic waiting times, and reducing costs. In addition, we would like to formally gather GP and consultant feedback, as well as patient satisfaction with teledermatology services. Our future aims and outcomes will be to increase the management of benign skin lesions within the community in primary care, to maximize the efficiency of the patient journey, to deliver high-quality care at a lower cost, and to collect patient and GP feedback and satisfaction, which has been positive so far. We would like to thank everyone who were involved in the development of this teledermatology service. Thank you very much for listening.